Welcome to the November edition of Pain Research Working Group. I'm going to give everyone just another minute before we get started, but just wanted to say hello. Okay, so I see it's 2 minutes after, so I want to go ahead and get started. First of all, welcome everyone. Thank you for attending this edition of Pain Research Working Group. Today, we are very pleased to have Dr. Elizabeth Loshin. She's going to talk about the cultural neuroscience of pain today. Dr. Loshin is an assistant professor of psychology and director of the Social and Cultural Neuroscience Lab at the University of Miami. Her passion lies in combining her training in anthropology and neuroscience to explore the bidirectional relationship between culture and the brain. She's investigated how humans acquire cultural beliefs and practices through imitation, how these beliefs and practices shape psychology and brain function by comparing individuals with different sociocultural backgrounds, and how both processes impact human health and healthcare. Along with the SCN lab members, she's currently focusing on how cultural experiences such as discrimination and social situations, for example, like doctor-patient relationships, influence pain perception and the brain mechanisms underlying it. So with that introduction, I'm going to turn it over to Dr. Loshin. I would encourage folks to go ahead and type questions in the chat if they have them, or you can wait until the end and we'll have a moderated discussion. Thank you very much for joining us today, Dr. Loshin.
Thank you for inviting me. I'm really excited to share our lab's work with this audience today. So I'm going to be giving a broad overview of a number of studies in my lab rather than going deep into only a few. So please ask for more details at the end on anything that interests you or seems unclear. As we all know, pain is both universal and costly. It's part of most major medical disorders, and it's the most common reason for people seeking medical care. And the Institute of Medicine estimates that pain costs $635 billion annually in healthcare and lost wages, and that was back in 2011, so I'm sure it's much more today. But pain is not the same for everyone. Many social and cultural factors modulate the pain experience. So the specific example of sociocultural modulation of pain I'll be focusing on in today's talk is that, broadly speaking, women and members of minoritized groups report greater pain with the same medical condition or same type of experimental pain stimulation. And yet, paradoxically, they also tend to receive less pain treatment than men and majority group members given the same condition. But the causes of these pain disparities remain largely unclear. And so my lab right now is really focusing on using a number of different techniques to try to understand where these disparities are coming from, with the ultimate goal of trying to design interventions aimed at mitigating them. Part of the reason it's been so hard to figure out where ethnic differences in pain report are coming from is that a single number on a numerical rating scale, like you might be presented with at the doctor, so we've all done this, you go to the doctor and they say on a scale of 0 to 10, how much pain are you in? But that single number we know is affected by many different factors that range from previous experiences someone has had that may predispose them to respond to pain in a certain way, to pain physiology, to the habitual responses that you learn for how to respond to pain, and finally, the pain reporting context. And culture likely influences pain at each of these stages. So in order to facilitate a deeper understanding of the mechanisms underlying ethnic differences in pain report, we've proposed a neurocultural model which delineates the particular aspects of culture that influence pain at each of these stages, and the potential psychological and neurobiological mechanisms linking sociocultural factors to pain. So as you can see here, our model starts at birth. And the reason is we wanted to account for the cumulative effects of cultural experience throughout the lifespan. And then when somebody encounters a painful event, we have that represented by that red line here. So as you can tell by the fact that we have a painful event, this model is mainly focused on explaining factors that might influence somebody's perception of acute pain. However, I think many of the processes we're looking at apply to chronic pain as well. So our main outcome is pain report, like we were just talking about, that numerical rating scale that somebody would answer or provide a response on in the doctor's office. And the reason is that that is the main piece of information clinicians use to make their treatment decisions. So we've proposed that cultural variation in stressful and painful life experiences prior to the painful event, such as discrimination or corporal punishment, may affect pain report through changes in peripheral inflammation, mood, and pain expectations and their accompanying neural systems. That regional variation in pain-related genes may affect pain through changes in neural mechanisms of sensory transduction. That cultural variation, emotional responses, and coping norms, such as the value placed on stoicism, may affect pain by changing emotional responses to pain and pain coping strategies and accompanying brain systems. And finally, we propose the cultural variation in communication and social norms, such as with those surrounding medical professionals, may affect pain report by affecting emotion regulation and social cognition and associated neural systems. So in the studies I'm presenting today, we've applied this framework to trying to understand the mechanisms underlying ethnic differences in pain report. And actually, I have a few slides on gender differences as well. So I'm going to start with a study focused on life history factors that may predispose people to respond to pain in a certain way. Specifically asking, how do life history factors contribute to pain disparities? So in this study, we were trying to understand the psychological and neural mediators of ethnic differences in pain. So as I had explained previously, members of minority groups in the U.S., typically African Americans and non-Hispanic and Hispanic identifying individuals, report more pain than people identifying as non-Hispanic white. And so we have those three groups represented in our participants in equal numbers, roughly equal numbers. And they underwent experimental thermal pain task during functional MRI. So we have a wand that heats up, it goes on the inner forearm. It's pretty painful. It feels like having a hot cup of coffee held against the skin, but the temperatures are carefully calibrated not to damage the skin. But we need to induce pain in some of our studies in order to try to study its mechanisms in a controlled environment in the MRI scanner. So we also gave people a battery of self-report measures of various life history factors that we believe to contribute to group differences in pain. So first we replicated higher pain report in the African American participants compared to the Hispanic and non-Hispanic white participants. So the African American participants are represented in this red line here, and the Hispanic and non-Hispanic white in these blue and green lines down here. So you can see this is the case both on average. There were three intensities of heat, all painful, low, medium, and high, applied to the arm. And then this was also true in terms of a steeper dose response relationship. So this means for every degree increase in temperature, the African American participants found that increase to be more painful compared to the other two groups. So in a two-step search for life history factors mediating the higher pain reports in our African American participants, we found that only participants reported frequency of responding to discrimination. So this is like, how often have you done something like filing a formal complaint? Mediated the effects of participant ethnicity on reported pain intensity. So just to give a little bit more background here, we had about 100 self-report measures where people were telling us about their mood and their stressful life experiences, discrimination experiences, previous experiences with pain, beliefs about the causes and consequences of pain and illness, things like this that made up this battery. And we first identified any variables that differentiated the African American group, because that's the group that was reporting higher levels of pain than the other two. And then we tested those as potential mediators or variables that explained this relationship, this higher pain rating in the African American group. So we found this discrimination related variable did, suggesting that a history of discrimination may predispose individuals to respond more strongly to physical pain. So perhaps negative socially painful experiences may predispose individuals to respond more strongly to physical pain. So then we turn to the brain, because now we were trying to understand what the neurobiological mechanisms of these differences that we observed might be. So we found that the frontal striatal system, which has been previously, oops, sorry, haven't been moving enough, my lights just went off, that have been previously implicated in pain valuation, modulation, and chronification. So here you see one component of this circuitry, the ventral medial prefrontal cortex. And here's the other part, the nucleus accumbens, which some of you may know is also part of the reward circuitry, or more so think of it as reinforcement and value circuitry in the brain. So these regions had a steeper dose-response relationship with painful stimulus intensity in the African American participants compared to Hispanic and non-Hispanic white participants. So I've just graphed average values from this medial prefrontal cortex cluster here. So you can see the red line is representing brain activity in the African American participants. So you can see as the temperature, the painful heat increases, these participants had a higher responses in this frontal striatal circuitry, which was not happening in the other two groups. And so here now I'm showing you all 4 sets of brain regions that showed this pattern of more sensitivity to increases in painful heat in the African American group. So the ventromedial and the medial prefrontal cortex, the middle frontal gyrus, and the nucleus accumbens. So these medial frontal cortex and nucleus accumbens together make up this frontal striatal circuitry that has previously been found to play this role in pain related to valuation, chronification, modulation. So it's sort of not necessarily central to the nociceptive process, to the more basic process of pain sensation, but kind of people's reaction to it to some degree. So 3 out of 4 of these clusters of brain activity each partially mediated the relationship between painful stimulus intensity and pain ratings. And in this case, the medial prefrontal cortex did so more strongly in the African American group compared to the others. Finally, in an exploratory analysis for relationships between regions more responsive to painful heat in African Americans and the candidate sociocultural mediators that we had previously identified, we found that the nucleus accumbens responses to pain were higher in those who had reported experiencing more discrimination, suggesting that a history of discrimination may sensitize the frontal striatal circuitry to pain. And what was particularly interesting about this finding is that you see a very similar pattern in chronic pain patients. So the frontal striatal circuitry, these same 2 brain regions and their connections, have been found to be able to predict who will go on to developing chronic pain after an acute injury. And we also know that early life adversity, negative experiences early in life, predispose people to developing chronic pain after an acute injury. So we were sort of starting to see this pattern that made us hypothesize that perhaps the stress of chronic discrimination might be acting like early life adversity in terms of predisposing people to chronic pain. It might be sensitizing this frontal striatal circuitry to pain in participants who had experienced more discrimination, the majority of whom were the African American participants. So to summarize this section, how do life history factors affect pain? In this study, we found that adverse sociocultural experiences like discrimination can influence pain and its neural correlates, which may help to explain some of the well-documented ethnic differences in pain. So in the second line of work I'm going to present today, we focused on pain communication. specifically asking, how does the doctor-patient relationship contribute to pain disparities? So in the first study in which we addressed this question, we had 80 participants, and we manipulated feelings of clinician-patient sociocultural similarity by creating artificial social groups in the lab. So this is a social psychology technique, and we're using kind of a variant on it. But basically, the idea here is instead of using real world sociocultural groups that have a lot of historical baggage, here we're going to create these artificial groups so that we can more sort of purely test how group membership in a general sense affects our process of interest. So in this case, our modification was that we didn't just say these groups were based on something totally random, like the original social psych studies have done, like how good you are at estimating the number of dots in a cloud of dots. That's one of the early examples. Here we told people, we had them fill out questionnaires about their core beliefs and values around politics, religion, and gender roles, things that people feel very strongly about. And we told them people in your same color group filled out this questionnaire more similarly to you. They share more of your core cultural beliefs and values than the other group. And we did this because we think this is one of the ways, or there's some literature suggesting this is one of the ways that people use demographic groups in superficial interactions, like if they're going to the doctor. They use these demographic cues and then make assumptions about sharing or not sharing core cultural beliefs and values with others. So we then assigned our participants to doctor and patient roles randomly, and then each patient had a simulated clinical interaction with an in-group clinician and an out-group clinician. And in these simulations, we used the same thermal pain induction procedure as in the previous study as an analog of a painful medical procedure. And the patients rated how much pain they felt as a result of that, the heat on their arm. It was always the same temperatures for both clinicians. And then how similar they felt to the clinician and how much they trusted them. So we found that even this kind of artificial group manipulation worked, as it has in many previous studies. Patients reported feeling more similar and more trust in in-group compared to out-group members, so yellow with yellow and green with green. But more interestingly, we found that as patients reported feeling more similar to and more trust in their clinician, they reported that the same temperatures on their arms hurt them less, suggesting that feeling more similarity and trust towards your doctor may decrease pain during medical care. So we followed up this study now with the real world groups that we were sort of trying to model in the previous study. So now we did a study where we actually did medical simulations pairing doctors and patients in racially concordant versus discordant interactions. So this was work led by my previous graduate student, now postdoc, Stephen Anderson. And these simulations were more realistic. Now, this was done in my lab at The previous work was done during my postdoc at University of Colorado, Boulder. So we have a room in our lab set up to look like a doctor's office. And in these simulations, our doctors were medical trainees and our patients were healthy community members playing the role of patient. But the pain induction was real and they had physiological monitoring. As you can see, this patient has electrodes, ECG electrodes to measure her heart activity. And they also had electrodes on their hands to measure palm sweating, which gives us an index of the autonomic nervous system. And so we found that particularly for our patients, our Black patients, they had reduced pain when they had a Black clinician compared to a Hispanic or non-Hispanic white clinician. And even more interestingly, we found a parallel pattern in their pain-induced physiological arousal. So they actually had reductions in sympathetic nervous system activity as indexed by this palm sweating measure with the Black clinicians versus the Hispanic or non-Hispanic white clinician, suggesting that doctor-patient racial and ethnic concordance may reduce pain for Black patients. And to dig into this further, we looked into some of the self-report measures we gathered, and we found that this was true to a greater degree for participants who reported having experienced more discrimination or worrying more about discrimination, suggesting that a concern over discrimination with ethnically or racially discordant doctors, which, given the demographics of the physician workforce, African American patients are more likely to have than racially or ethnically concordant doctors, because the majority of the physician workforce is only 5% of it is African American, 5% of it identifies as Hispanic, and the other 90%, some other group, many of whom are white. And so African American patients in real clinical contexts are less likely to have a racially concordant doctor than other groups. And this finding suggests that a concern over discrimination with discordant doctors may contribute to higher pain report in African American patients. So in a third study, also in collaboration with my former graduate student, Stephen Anderson, we wanted to know what the brain mechanisms were underlying trust-related reductions in pain. So I popped these faces on the screen a little bit early, so you're probably wondering what that's all about. In this study, we wanted to manipulate doctor trustworthiness, but in the scanner environment, which is more difficult because we can't have an extended interaction between people. So we did it using a totally different approach. We used these faces designed by another lab, Alex Todorov's group, that does a lot of work on facial first impressions. So these faces are digital avatars that were developed based on thousands of ratings from real research participants to look either highly trustworthy or highly untrustworthy. And there's actually an algorithm that can be applied to new faces to make a trustworthy or untrustworthy version of that face through manipulation of certain facial features, like the inner eyebrow corners are high in the trustworthy faces and low in the non-trustworthy faces. So these two examples are at the extremes of this continuum, and here you can see the neutral face in the center. So we created a virtual medical interaction with these high and low trustworthy doctor facial identities, 24 of them per person in the MRI scanner who is our patient. And so here's an example of what that interaction looked like with both the high and low trustworthy version of a clinician. So a given patient only ever saw one clinician so that we didn't make it obvious what we were doing. But this just has the two side by side, so you can kind of see what this looked like. So each clinician would introduce themselves, the patient would look at them briefly, and then the clinician is holding this thermode, which is the pain induction device we use that was actually strapped to the participant's arm while they were in the scanner. So the heat would start, the doctor would tell them the heat's about to start, then the participant would actually start feeling the painful heat on their arm. And when that was over, the doctor would come back on and ask them how intense was the pain and how unpleasant was it, mirroring what you get asked in the doctor's office anytime you go in with a painful condition. So what we found is these faces worked as we had expected, and people found the more trustworthy faces to be more trustworthy. And this was based on ratings prior to them getting in the scanner, so it didn't affect what was happening in the scanner. They weren't asked to rate trustworthiness while they were in the scanner. But more interestingly, we also found that people rated the pain as less unpleasant, and in a different set of ratings that I'm not picturing here, as also less intense when their doctor was more trustworthy. So it seems that having a trustworthy doctor actually made decreased participants' feelings of pain, which is similar to what we found in our previous study. So now this replicated these clinician trust-related reductions in pain. So now we could go look at the brain activity and try to ask, well, which neural system was getting its volume adjusted by this trust? And so for this, we actually used a multivariate brain signature, sort of a brain biomarker of pain developed by my postdoctoral mentor, Tor Wager. So this is a pattern of brain activity that was developed to predict patients' pain ratings. It was created by looking at the pattern that was most predictive of a group of patients' pain ratings. And then it's been applied in many other contexts to many other groups of subjects, many other types of pain, both patients and non-patients, and has been found to perform quite well. So we use this, and what we found is that the expression of this neurologic pain signature was reduced with high trust clinicians in the red bars compared to low trust clinicians in the blue bars, specifically during the most painful heat stimulations, the highest temperature heat stimulations. And also to some degree during unpleasantness rating. And if you recall, it was the pain unpleasantness where we had our stronger effects in the pain rating. So it kind of parallels that pattern. And that finding during the rating period may reflect a carryover effect from the actual pain stimulation period. So this suggests that neuroresponsives sensitive and specific to pain may be decreased by trusting your doctor. So to summarize this section, how does the doctor-patient relationship contribute to pain disparities? Doctor-patient similarity can reduce pain and its neural correlates, both in terms of sociocultural similarity and ethnic and racial similarity, and trust can also reduce pain and its neural correlates. So in a final line of work, this is our most recent work, so much of this that I'll present is in progress, all but the first study. We actually looked at all the studies I've presented up until now, we're trying to understand pain disparities from the perspective of the patient. Now we're going to focus on pain treatment disparities, looking at the clinician. So this wasn't actually part of our original model, so here I'm adding pain treatment, specifically asking how do clinicians contribute to pain treatment disparities. So in a first study, we wanted to understand the sociocultural mechanisms underlying gender biases in pain treatment. So this question had been studied experimentally before, but there were several important aspects of our study design that allowed us to gain new insights. So first, we used videos of real chronic pain patients from the UNBC McMaster Shoulder Pain Expression Database. So you can see two examples of those here. These are patients with shoulder injuries at a rehab clinic, and they're being asked to do range of motion exercises with their injured shoulder. And this is just video of their faces while they were doing that. By using videos of real pain patients rather than the patient actors or digital patient avatars that had been used previously, we were actually able to study genuine pain behaviors. And there's a fair amount of evidence that the expressions and the bodily behaviors that people make when they're actually in pain differ quite a bit from the posed expressions that a lot of people use in these kinds of studies. And the second thing we did, which was also afforded by us using these videos of actual patients in clinical pain, was that we controlled both of the patient's report of their own pain that they were experiencing while that video was being taken, and also the intensity of their pain facial expressions, which was calculated using the facial action coding system data that was provided with the videos. So this is a standardized rating system for pain or for any kind of facial expressions based on trained raters making ratings of muscle movements of about 30 some odd different muscle groups on the face. So it's thought to be very objective. The raters have to have lots of training and are only allowed to use this fact rating system if they meet certain criteria of accuracy and consistency. So this then allowed us to ask when or were the pain ratings of the clinicians perceiving the patient's pain, did they differ when the objective metrics, the patient's own pain report and their pain facial expression intensity were the same, as potentially evidence of a true bias. So that's what we found. Men were believed to be in more pain than women with the same pain behaviors. And so there were two studies where we did this, an in-lab study with 50 participants and an online study with 200 participants, and we found the same pattern. And then we tried to understand why this might be. So we gave a number of questionnaires, including these questionnaires about participants' beliefs about the typical pain sensitivity of different demographic groups. So in this case of men and women. So how sensitive to pain are men and the typical man and the typical woman, how willing to report pain is the typical man and typical woman, and how able to endure pain is the typical man and the typical woman. So what we found is that both male and female perceivers, so this would be the equivalent of the clinician, believed women to be more willing to report pain than men, and that these these ratings of how willing they thought women were to report pain compared to men partially explained the bias in pain assessment on the part of the clinician. So partially explained the fact that men were believed to be in more pain than women with the same pain facial expression, suggesting women's pain behaviors may be discounted based on the belief that women are more expressive than men. And what was, sorry, just before I move on, what was really interesting about this is in this particular stimulus set, there are no differences, there are no gender differences in the intensity of the pain facial expressions. The male patients and the female patients, on average, have the same intensity of pain facial expression. And many of the studies in the literature bear that out as well. When people have actually studied the intensity of male and female pain facial expressions, there has not been a consistent finding that women are more expressive, but that is the social stereotype, that women are more expressive, and that seems to be affecting clinicians, or in this case, lay people's perceptions of others' pain. And so finally, we asked our pain perceivers, our participants, to rate which therapy they thought would be most efficacious for each patient, psychotherapy or pain medication. And we found that our participants believed that psychotherapy would be more efficacious for a higher percentage of female patients than male patients, suggesting that undertreatment of women's pain may be driven in part by beliefs that it is more psychological in nature. So the final set of studies are underway right now, and we tried to ask basically the same question about mechanisms underlying pain treatment disparities, but now looking at ethnic and racial disparities in pain treatment. And for this, we actually had to create our own stimulus set because that McMaster stimulus set we used in the previous study did not have enough racial or ethnic diversity to ask this question. So as you've gathered from my talk so far, in a number of our studies in the lab, we induce pain and we also take video. So we have many participants, we have video of many participants undergoing our painful stimulation procedure. And so when they gave us permission to use their videos in this way, we were able to use those to create this stimulus set of close to 100 individuals experiencing pain, so and exhibiting genuine pain behavior. So this is just a little sampling. And what I hope you can see from this sampling of different individuals making real pain facial expressions is there's so much diversity in terms of what their expressions look like. Some of them are very intense, some of them are very subtle. There are different parts of their faces that people are moving more than others. So I think to the observer, they're all pretty unmistakably pain facial expressions, but the variability in what they look like helps to demonstrate why it's important to use genuine pain behaviors when trying to ask these types of questions. So we're using these stimuli. Well, okay, so first I'm going to talk to you about one other important aspect of the stimulus set. So we also quantified the pain facial expression intensity just as was done in the McMaster set, but now using an automated approach. So we have this software, iMotions, that does automated fax coding, and then we calculated a score previously developed by Pratchkin and Solomon to get a metric of pain facial expression intensity by summing the values for a number of these facial movements that are shown here that are particularly characteristic of pain facial expressions. So we were able to use the person in the video's rating of their own pain and this metric of pain facial expression intensity. And now we are scanning clinicians in the scanner, and they're seeing these videos of patients and being presented with a medical vignette. And so these are simulations again, but they're told that the videos represent snapshots of the patient during a clinical exam of their injury. And there's some randomly generated variability in these medical vignettes that makes it more realistic, but doesn't introduce any systematic patterns relative to the patient's demographics. So there we're trying to look at what brain responses might predict how the clinician assesses the patient's pain and makes treatment decisions, and to try to kind of understand if potentially one of the factors driving these pain treatment disparities is a variability in how much the clinician's own pain circuitry in their own brain is activated when looking at patients in pain, particularly patients of different demographic groups than their own, because there's a literature in social neuroscience that has demonstrated that when you look at someone in pain, the pain circuitry in your own brain lights up, but not to the same degree for everybody. More so if you feel more similar to that patient. So that's what we're trying to test in that study. And the other study, we're actually using live medical interactions with clinicians in training, med students, residents, and fellows from across the country. This is our COVID study, our conversion of a grant aim to be COVID compatible, so it's fully online. So, and I think that studying biases in telemedicine, particularly for pain assessment and treatment, is particularly important because I think the modality of telemedicine has risen greatly during the pandemic and will not go away once the pandemic recedes. And I think it also introduces some new potential avenues for bias to creep in. And so we're trying to understand those dynamics in this ongoing study. So to summarize my whole talk in terms of the implications, we found that both sociocultural life history factors and sociocultural elements of the doctor-patient relationship can affect pain, pain treatment, and their neural correlates. Thus, these factors should be taken into account in pain assessment and treatment more so than they are today. So I'm just going to thank my collaborators, my graduate students, Stephen Anderson, Morgan Gianola, and my former postdoc advisor, Tor Wager, who is still a main collaborator of mine, and my funding sources, and all of you guys for listening. Thank you very much.
Thank you for that wonderful presentation. That was incredibly interesting, and we have a couple questions already in the chat box. So I'm going to go ahead and read these out and invite the questioner to ask follow-up if they think it's relevant, and also invite others to put their questions in or think of questions. So I see a couple of questions here from Bob Kern. So we'll start with this one. Were other potential negative social determinants of health, poverty, low education, living in under-resourced settings, that are also likely associated with discrimination and trauma experiences controlled in the imaging study?
Yes, so we controlled for socioeconomic status. In this particular sample, we did not have group differences in SES between the African American group and the other two groups. Actually, the Hispanic group was slightly lower SES than the other two, but we tested because there wasn't a significant difference between the African American group and the others where we found the difference in pain rating. We ultimately did not include that in the final models, but we tested it initially and did not find that it controlling for that changed the outcomes. And it's interesting because I think it's an obvious hypothesis for what might be driving some of these effects. However, most of the previous studies in the literature documenting these disparities, ethnic and racial disparities in pain report, have also controlled for SES and found that it did not change their outcomes. So it seems to be more than just SES, but I certainly think that that is probably part of the bigger picture. And in fact, we have a grant under review right now where we're trying to look at the role of structural racism in this whole picture, because I think structural factors probably act on pain, if they do, which I suspect they do, through different mechanisms than interpersonal experiences of discrimination. So I'm guessing that they're additive, but not acting via the same mechanisms.
And there's another question from Dr. Kearns, and I'll go ahead and ask this one too. How well is measurement of trust discriminated from other similar constructs, such as perception of respect or validation of a pain complaint or even therapeutic alliance?
Yeah, so I'm sure that particularly in these sort of relatively superficial interactions that we had in our medical simulations, there are a number of highly correlated variables with trust. And in fact, in that first study I presented, we ended up creating a composite measure of several variables between or several questionnaires measuring both trust and feelings of sociocultural similarity. They were so highly correlated, we could not separate them. I suspect in ongoing doctor-patient relationships, these start to become more separated as people have more individual interactions and experiences that affect the trust within that relationship. But yeah, I think in superficial, brief medical interactions, trust is highly correlated with other variables. However, I don't think that necessarily presents a problem for a potential intervention aimed at sort of harnessing that to reduce pain during medical care, because I think even some of the strategies we used in the first simulation could be used to increase trust along with a number of those other sort of aspects of rapport and still get the benefits.
I think the first question, there's another question on there, does race and gender, the experiment of delivering the pain affect the outcome? That was a question referring to study 1, where you were having painful stimuli in the scanner. Did they actually know, were they exposed to the person who was thought to be delivering that
Yes,
painful stimuli?
yes. So this was a very long study. There were actually 2 other it was me and a couple other postdocs, and this was this early data that I collected during my postdoc. And the participants were with us for almost 6 hours. And the experimenter was the same experimenter for all the participants. He was a white male in his mid-30s. And I didn't present this data because there's a lot of analyses in that paper, but we did find that the 2 other sort of candidate mediators were how racially similar participants felt to the experimenter and how much they trusted him. And for the African American group, it was lower for both of those variables than for the other 2 groups. And we found that those ratings of trust in particular were also related to some of the brain differences that we saw. So I think that was a factor. And I think the findings we had in that subsequent study, where we actually actively manipulated doctor-patient racial and ethnic concordance, corroborate that or are consistent with that finding.
So I'm going to invite folks, if they have any other questions for Dr. Loshin, that they can jump in right now.
While people are thinking about questions, one reaction I had, and kind of looking at the broad scope, and I think the ultimate goal of your research is to increase the quality of care for individuals who are reporting pain, and I think beyond having a more diverse clinical staff, which I think is, given the statute, they have 5% are like Black or African American, 5% Hispanic, and the rest are likely Caucasian or other. What are things that might be able to, how does your research translate to what might we be able to do now in terms of finding ways to deliver equitable treatment and keep biases in check in a way that's going to improve the quality of care that we can provide our patient populations?
Yeah, so I think that there are kind of 2 avenues suggested by our findings so far, and I suspect will be kind of further elaborated upon by the 2 studies I said we're running right now that are specifically focused on provider biases. But basically, I think the studies we've already done on doctor-patient sort of concordance and trust suggest that approaches that we could use during clinicians' training to teach them ways to establish rapport and feelings of trust and similarity with their patients outside of demographic concordance potentially have a payoff of reducing pain during medical care, potentially via a decrease in anxiety. So the findings we had in of the African American patients showing this reduction in both pain report and physiological responses to pain suggests that there's probably an anxiety reduction component going on with the racially concordant providers for African American patients, particularly those who have experienced more discrimination. So I think other strategies of doctors trying to establish that they have something in common with their patients, which I think is, the assumption is that that's not the case, right? There's already this pretty big power differential when you're going into a doctor's office. You don't have medical training, they do, you're vulnerable, you're in pain. And so I think even some of the really superficial strategies like we used in the first study with the sort of questionnaires about core beliefs and values, it could probably, based on the social psych literature, be even more superficial than that. I mean, you can get people to feel this group affiliation just by learning that, like, they share the same birth month with somebody or have the same letter that starts their first name. So I think there can be strategies used by clinicians to establish this feeling of common ground with their patients outside of demographic concordance.
This is Bob Kearns. I just greatly appreciate this. It's just such interesting work, and I'm older and can think back to many different divergent, historically divergent areas of research and conceptualization that potentially apply here. With regard to your last point about the idea of trying to intervene to promote a sense of shared values or prior experiences or like that. I think there's an old psychotherapy literature that sometimes that can undermine treatment. It's not necessarily always a good thing, meaning that when clinicians identify with their patients, they may underappreciate the pathology of the person in their the patient. And that can lead to unintended delay in treatment or identification of more, et cetera, et cetera. So I think it's even though the research that you're doing kind of leans in toward this idea that it's a good thing to promote a sense of shared values or experiences, commonalities, et cetera. I think there needs to be some caution about what the clinical implications of that might be.
Yeah, thank you. I am familiar with a fair amount of research on the therapeutic alliance in clinician-client psychotherapy relationships. Not so much with that particular aspect of it, though. I'll have to look into that further. But yeah, I definitely think this work is between where we are now and where we would have to be to design and test an effective intervention. There's a pretty big gap. But I think one thing that I'm hoping the imaging study that we're doing can clarify is try to better understand which factors are changing the sort of vicarious pain that the clinician is feeling. And that's another thing that, because we have now brain measures of what of circuitry related to the pain experience in the pain observer, in the clinician who's being scanned. But there is a similar caveat there, which is that during medical training, doctors are taught to distance themselves to a degree to prevent burnout and remain objective. And so I think it will be kind of interesting to try to see what the balance is between, doctors who seem to be empathizing more based on this neural measure and how that relates to their treatment decisions. My prediction is, the more they feel the patient's pain based on what their brain is doing, the maybe not necessarily the more pain medication they'll prescribe, but maybe the more accurate their prescribing will be and their pain assessment. Because we have the person in the video, we have the rating that they said, that we have how much pain they said they were experiencing. So we're not in this work, it's funded by NIDA, and they were very clear when I put in this application, they're not interested in funding things that are just like, give people more pain medication, particularly more opioids. We know that that's not necessarily the solution. It's more about appropriate treatment. And so what I'm hoping are currently under data collection studies will help us figure out is what can help clinicians have a better understanding of what each individual patient is experiencing from a pain standpoint, rather than, just across the board, everybody gets more pain medication or other kinds of treatment.
Well, one more comment. I also love, as much as I've been exposed to it, reading and hearing Jeff Mogul talk about, basic animal research, where he's looking at particularly gender. I think there was some hint of this, an allusion to this in the first question that came up in the chat, where rats and mice behave differently depending on the gender of the research assistant. And then they found out it wasn't just the gender. If a woman RA wore a man's t-shirt, it led to differences as well,
It was
because
olfactory
potentially
cues.
hormonal, olfactory kinds of things. So, all of this leads me to think that, placing your science in this, broader context of people looking at individual differences and social interactions in the context of clinical care, but also, even just basic expressions of pain and how it's reflected in brain. It's just so interesting and compelling. And I love thinking about this stuff in that much more broader integrative context. I guess the thing that comes to mind about what you're doing for me also is that, studying race or gender in isolation of each other and potentially other important characteristics like sexual identity, even, or subpopulations within whites or blacks or Hispanics, etc. So the concept of intersectionality comes to mind. Of course, that adds an incredible amount of complexity, but it does. I think it's, fair to say it is, there are limits to studying any one characteristic in the absence of paying attention to so many others.
Yes, absolutely. So as kind of a first step in these lines of research, we did sort of try to separate these elements a bit, although I will say that in the first study I presented, the study where we were looking at brain differences with people in pain in the scanner, looking at the racial and ethnic differences, we are now working on a paper on the sex differences in that study. So in that study, as in many in the literature, women reported more pain than men. And we're finding brain differences, but what's interesting is they don't seem to be kind of similar to the pattern you're seeing for the ethnic and racial differences. And so, yeah, that is forthcoming. And the stimulus set that we have designed, the video-based stimulus set, we specifically, it is sex balanced and also represents the 3 racial and ethnic groups where most of the disparities work in the literature has been done. And so typically, in our studies up until now, we just haven't had the number of subjects necessary for the power to subdivide the sample by interactions between different demographic categories. But in these studies we're tackling right now, we will, because we specifically designed them to do that. So I hope I can give more answers in the coming years on this question of intersecting identities. I suspect if you're, say, an African American woman, so you're part of these 2 groups that are affected negatively by these disparities, it's at least additive, if not multiplicative, the effects of these biases. So I hope to be able to say more about that soon.
It's interesting, even talking about intersectionality. One of the issues that comes to mind for me is being a clinician that primarily treats veterans, that there's often cultural identities embedded within that, like a military culture. And I've had many veterans talk with me and ask if I've been in the military, and knowing that there's higher rates of chronic pain in the military, and that that's been a barrier that we've had to discuss, and that, can you understand what I've been through? And this relates to pain, but also PTSD and substance use and other issues.
Yeah, absolutely.
Other
Just
intersecting identities.
anecdotally, we have had a handful of veterans in our studies. And again, anecdotally, but my experience fairly consistently across all the participants I can remember was that they tend to be way on the low end of the pain report spectrum. I've had a handful of people I can remember specifically who were just giving like zeros or ones on a scale of 0 to 10 for these pain stimulations and saying like, that doesn't even feel painful. That's just like uncomfortable, or it's just, and I think that the training that occurs, well, I suspect that there's a selection bias. The people who choose to enlist already, there are certain characteristics of those individuals relative to the general population. But then furthermore, I think the training that happens in the military further emphasizes stoicism and increasing your pain tolerance, etc., which I think can sort of work against people when it comes to then injuries related to their service, because it can be a lot harder for clinicians to kind of decipher what they're seeing and understand the patient's experience. And then also, I guess what you were saying is this potential of having clinicians. I imagine many clinicians at the VA have not necessarily served themselves. And so then there's sort of this discordance there.
This is Bob. I can't help but acknowledge, though, of course, that veteran status is in National Health Interview Survey data actually a predictor of higher prevalence of chronic pain than in the civilian population, and that among veterans who report chronic pain, their ratings of pain intensity are higher than those of civilians who also report chronic pain.
Oh, that's interesting.
The other thing that I'd bring to this group that's been a new insight for me, listening to a veteran engagement panel in our pain management collaboratory, is the I guess suggestion from veterans that their experience in military treatment facilities, in particular, while they were in service in the VA, that the care they received and maybe the level of trust, respect, and some of these other variables may differ as a function of branch of the service and rank in service. It's a feeling that people lower on the totem pole are disadvantaged relative to those who are in more prestigious or higher level roles in the Department of Defense. So it's very, even there's
right. Some of these disparities are sort of recapitulating themselves. Yeah, in the military hierarchy.
Yeah, there's probably more variance there than we might intuit in terms of at least veteran perceptions of their interactions with healthcare providers.
Yeah, the point you made about veterans with chronic pain potentially reporting higher levels of pain than civilians with chronic pain kind of reminds me of some findings in the corporal punishment literature. So if you're imagining corporal punishment as a previous experience with pain that might predispose you to respond to future painful events in a certain way, the literature is very mixed in that case, where in some cases studies have found that people who experienced corporal punishment as children have a higher pain tolerance, a lower pain sensitivity, and others it's exactly the opposite pattern. And one of the variables that seems to make the difference is whether that corporal punishment was perceived as traumatic by the child, whether it was perceived as sort of abusive versus normative. And so I imagine that the experiences in the military might break down along those lines, where I'm really not speaking from a position of a lot of personal knowledge of this. I'm just sort of speculating. But perhaps if you've had military training that emphasized sort of stoicism, alone, that might say increase your tolerance and decrease your sensitivity. But then if the painful experiences have occurred in sort of a traumatic context of combat, then perhaps that has that opposite sort of sensitizing effect that, say, corporal punishment that was perceived as abusive might have as well. Not that I'm equating the two, but only in the way that the perception of what that pain means seems to matter in terms of whether that pain is previous pain experience is habituating or sensitizing. All right. Any other thoughts or questions?
I think so, and I think we're at the top of the hour. This was really such an interesting, fantastic talk. We really appreciate you coming and joining us today. Dr. Loshin has kindly offered to share a PDF of her slides for those who are interested. So if you are, you could contact Ross or I, and we'll be happy to pass those on to you. We appreciate you being here today and taking your time to talk with us and share your work. And thank everyone for their attention and their questions and the discussion. And we will talk to you again next month. Thank you, everyone.
Thanks a lot.
Bye.
Thank you.
Bye.